I'm Lee Warren. I'm a neurosurgeon in North Platte, Nebraska, and moved here from Casper, Wyoming, where we practiced for about 5 years. And before that, I was in Alabama, and then spent several years in the U.S. Air Force and some time in Iraq, and so I've been around a little bit. And we learned that the Great Plains Health System was recruiting a neurosurgeon to start a brand new neurosciences program here. And it just seemed like a great way to add some value to the area and spend the last, hopefully, third of my career in a place where they'd never had neurosurgeon before. The hospital I was working at in Wyoming acquired another hospital in 2018, and so we found ourselves in the market for a new microscope. And I was just doing research and due diligence. I'd been for 20 years a user of traditional microscopes and really believe in the power of microscopy to make surgery better and safer. And in the course of just doing some market research, I discovered an ad really for a manual exoscope that looked like a really potentially game-changing technology. So I requested a trial and really found the ability to stand straight up and look straight ahead for surgery, and rather than being tied to the traditional limits of having to have your head in the same plane as the microscope, was very freeing, and it added a lot of value to our staff and educational purposes. And so I started using the manual exoscope alongside the traditional microscope for a couple of years. Anybody who has worked with the traditional microscope for very long knows that you have a lot of fatigue on your body if you're looking at an extreme angle towards L5-S1, for example, or C3-4, or sometimes in cranial procedures where you need to look around or behind something. With the traditional microscope, you literally have to have your head and body position looking the way that the scope is looking, and that over time starts to add neck pain and back pain and strain on your body. And so the exoscope immediately frees you from all of that. Like, you basically put the scope where you want to look, and you get to look straight ahead at the monitor, and it just tremendously improves your quality of life. So you spend hours doing a very delicate task. So you're needing your body to be relaxed and comfortable and have your hands very precisely performing certain things. And then you're adding in a body position that's not comfortable, that you need to hold sometimes for long periods of time. And so you start to become aware during the procedure that you're trying to be really careful and something's hurting or something's awkward. And so it really becomes almost competitive to the task at hand at some point. The nature of the way the scope is working and requiring you to move your body is challenging, and sometimes it's also really challenging for the PA or the assistant on the other side, resident, or whoever might be helping you with the case, because the more extreme the angle is, the more awkward they're having to stand as well, which makes it difficult for the technicians to pass instruments. And sometimes in larger patients, especially at L5-S1 in the spine, the anatomy is such that the scope almost has to sit on the patient's body in order to look down the disc space angle. And so it really, ergonomics are a huge factor in the ability to perform the procedures safely and comfortably. I think all of us who do this work are aware that neurosurgeons and orthopedic spine surgeons have a huge percentage of us that have cervical spine surgery in our lifetimes. And it has to have something to do with occupational hazard and the way we hold our heads all the time. We hold our head at a 60 to 90 degree angle for hours at a time, for 3 days a week for 30 years. That's going to take a toll. When I first started using the scope, I became really aware of how much better I felt at the end of a long day of surgery. You find yourself noticing that your neck doesn't hurt or your back doesn't hurt. My PA is commenting all the time on how she doesn't have to, do an hour of yoga at the end of surgery day anymore, because it feels so much better to use the exoscope. The ergonomics have been taking a toll on my body and my sort of peace of mind, and I wasn't even really aware of it until I had an option. And so it is a digital image being presented to us, but the picture quality is as good or better as what I was used to seeing through my binocular headpiece. And so when I have the same ability to manipulate the amount of light and the amount of magnification, and I don't have the loss of clarity when I zoom up extensively. And so I feel like they've threaded that needle really well between the two worlds. Sure. So one real advantage of the digital microscopy is we're not stuck with just what the light and the magnification shows us. We can actually flip through a variety of different image modes that the software creates, where we can enhance, or much like using Photoshop, we can choose what we draw out of the image being presented to us, which really helps to create contrast sometimes between, for example, a nerve or some scar tissue. It's not just about how much light or how much magnification anymore, so we can manipulate the colors in the field. It sort of reminds me of working with fluoroscopy in a sense, that we can choose what we want to emphasize, and the digital microscope allows us to do that in a really new and exciting way to me. One of the limitations, at first it felt like, with using a microscope of any sort while you're also navigating hardware, for example, or for spine cases or brain biopsies or tumor resection, is that we've always had to have two systems in the room. We've had to have the microscope and its monitors, and then the neuronavigation and its monitors, which creates a lot of clutter and a lot of technological issues of how many cables are we running under the table that we have to not trip over and those sorts of things. And now we've got the ability to synthesize those images on the same monitor. So we're going to be able to put our neuronavigational monitor, for example, that same data set onto the monitor for the Aeos from Aesculap, and that's going to allow me to reduce the amount of material, equipment in the room, and also allow the staff to, for the first time I think, start to see in front of them what we get to see in our minds as we're using these two systems, where the staff will be more immersed in the procedure because they get to see all of this happening in real time on the same screen. It's really exciting to me. One of the big differences between the manual exoscope and the Aesculap Aeos robotic exoscope is that I have the ability to add waypoints and saved positions of the scope without having to manually reposition it all the time. I can even have somebody outside the sterile field control the movement of the scope once I've programmed it. And so we have this great amount of control over where the scope is looking and how many different places we can look around a tumor, for example, or behind a nerve, or when we're trying to find a disc fragment. And we don't have that same amount of constantly reaching up and moving the scope to some arbitrary position. And so it's allowed us to start thinking about that we can map out this case, and when do I need to look behind this tumor and around this corner and all of that. And those points become saved, even zoom and focus points become saved, and it really, the scope, like I said earlier, becomes part of the procedure, becoming another instrument in my ability to carry out that operation. When we think about how we're going to accomplish a procedure, for example, we think about, I'm going to need to look behind this tumor and secure blood vessels. I'm going to need to look on my side and make sure that I've got the brain and a plane between the brain and the tumor. And I'm going to need to constantly be looking back and forth to make sure nothing's bleeding deep to the tumor that I'm working on, etc. And so we can kind of program out all of those movements at the start of the case when we're beginning to decompress the tumor, for example. And then we can sort of set a map of every 30 seconds I want to go check behind here and make sure nothing's bleeding. And we can sort of build the case ahead of time in our minds and in the software that really takes some of the randomness out of the procedure and really gives us an opportunity to create a game plan, if you will, and have the technology help us accomplish it. I think the robotic movements give me a little bit more precision in that I can save points where I'm going to look in exactly the same place with exactly the same amount of magnification and light as I had the last time I looked at that spot, without having to actually manually move the scope and try to get it to that same spot. I can just touch a button and it'll take me there. And so the scope allows me to reduce some of the guesswork and some of the hard work of actually trying to get to the same spot and make sure I'm seeing the same things all the time. One of the most, I think, exciting and really unexpected benefits to me of using the Aeos from Aesculap has been that we have the team all of a sudden getting immersed in the surgery. Before we were using big monitors with our microscopes, the scrub tech and the circulating nurses and the anesthesia personnel and other people in the room basically were just waiting around for us to tell them when we needed them to go get an instrument or go do this or do that. And they didn't really ever understand what was happening inside the patient. And now all of a sudden everybody in the room has got 3D glasses on and they're experiencing the procedure just like I am. And what we've noticed is the circulating nurse will leave the room and I'll say, "Where are you going?" And they'll say, "Well, you're about to need this or that." They're anticipating how the surgeon surgery is going to play out. And they're becoming part of the process rather than just waiting around for somebody to tell them something that needs to be done. We're seeing students come in the room and PACU nurses and people come into the room because now they're able to see what their patient is experiencing. And now I'm hearing conversations in the pre-op area between a nurse and a patient saying, hey, I've seen him do this. Here's what you're going to experience. It's really safe and you're going to be happy with the outcome. So the whole OR team, from pre-op to anesthesia to post-op, is now participating in the procedure because of this technology that Aesculap has brought us, and it's been really beautiful, and I think has really expanded our sense of teamwork, and everybody's a lot more interested in what they're seeing now rather than just kind of waiting for the case to be over. Everyone can see exactly what we're seeing from our perspective. Often we'll have a student, for example, with on 3-step stools trying to look over my shoulder during a surgery, and they can't really see what I'm doing or really understand it. But now in 3D, they can immerse themselves into the patient and see exactly where my instrument is. When I put a nerve hook under the L5 nerve root, for example, they can feel that and see it, and people react to it. You can see their body language change when something bleeds, or when nothing bleeds in my OR, of course. But when something happens, they see it and they're experiencing it and feeling it. And so that's led to better questions. People are reading about cases beforehand and asking questions, and they're learning more. It's created this learning environment in our OR. I think the ability for the attending and the resident to be seeing the same things, having their hands in the same place virtually on the monitor, will add a tremendous amount of value to training. I think it's probably the most exciting thing I've seen in the visualization aspect of neurosurgery in my whole career. And I think it's going to translate for academic surgeons into a better way to train residents, because residents really have never been able to understand what's happening in an operating room. And the first several times you try to learn how to do a procedure, you're basically just doing what you're told and taking baby steps. And now they're actually able to see what's happening inside a cervical discectomy, for example, that they could never see before. And so the residents, I think, will be much more prepared when they actually are able to start doing surgery. And I think it's going to shorten learning curves and really advance. I think the graduates in a few years who have trained on these systems are going to be way ahead of where we were when we finished our training years ago. I think if somebody was considering using the scope, if I was talking to a colleague, for example, about the things I've learned from going from a traditional microscope to the Aesculap Aeos exoscope system, I think the big thing is you're adding a little bit of equipment. If you're not currently using external monitors in the room, for example, on your scopes, and a lot of us have wall-mounted monitors, for example, for our scopes. But if you've got platform-mounted monitors that can roll around, now you've got the problem in your operating room of extra equipment to manipulate around all those people that you're working with. And so what we found is that putting some thought to where your eyes need to land for you to stand comfortably. In other words, if I'm going to do a cervical discectomy, for example, I've got myself and the patient and my assistant and the scrub tech and anesthesia here. I need a monitor that I can see, so I've got to be able to have my assistant's head not in the line of sight that I need to have, so I've got to figure out where that monitor needs to go so I can see clearly without having to strain my body to do so. And we found that for me, on an anterior cervical, having the monitor to the right side of me across the table, having my assistant directly across from me and the scrub tech there and the scope base here really is the most efficient and easy way to set that room up. But you have to think through that before you start your case. It's awfully hard if you have the monitor at the foot of the bed and you figure out you can't see it because the scrub tech's in your way. It's awfully hard to move it during the case. So I think the biggest thing for me has been thinking through that, dry runs before we do a case to set the room up a few different ways and see what works best. And once you dial it in, it's set. But you do need to spend a little bit of time thinking through it. That's words for the wise. So I've heard that some surgeons are concerned about moving from a sort of a focused, looking through binoculars where your world is shrunk down to what you're seeing in the OR, to a whole room of things to see, and maybe the concern about sensory overload. And I would just remind surgeons that we do lots of surgery without the microscope. We do craniotomies for subdural hematomas and carpal tunnel releases and ulnar nerves and all kinds of things without the scope. And you're already doing those procedures without tunnel vision. And so I would just say, if you're concerned about it, give it a try. Go to a demo and use the scope. And what you'll see, I think, is not any degrading of your worldview, but a great enhancement of your worldview of accomplishing that operation. I think really an important advance for me was the idea that I didn't have to be tied to the direction that the head of the scope looked. It's really an elegant evolution of thought of how you can accomplish these procedures. So for me, moving from the traditional scope and the head of the scope being in front of me to having my eyes able to see the entire room and the monitors and the facial expression of my assistant and all of those things has played into my ability to accomplish the surgery in a really elegant way. And so I think moving away from the microscope was something unexpected because I was a die-hard microscope user and always have been. I think it's the best way to accomplish surgery. And I've preached that for years. Like, you're a better spine surgeon if you use a microscope than if you don't. And I would argue that with anybody. And it was one of those things where you could see microscopes had kind of plateaued, right? There wasn't a huge amount of room to go and how they could evolve over time. We've gotten the scope that we had, for example, the best microscope I've ever had, recently purchased traditional optical microscope, beautiful piece of equipment, brilliant engineering, $500,000, and never saw it coming that something would come completely out of the box and change my thought process about that. So it wasn't like Aesculap just slightly evolved the microscope to something better. They just came out of nowhere with a whole different idea. It's taking the best optical equipment you could find, the best lenses and the best magnification and light, adding the digital piece to it so we can manipulate the image and the color quality, separating us from having to have our body tied to the head of the scope, allowing the entire staff to see in 3D. All these things have kind of cumulatively, just to me, changed the game enough that I no longer own a traditional microscope. We have 2 Aesculap Aeos scopes in our building, and I'll never go back because I can do everything I've ever been able to do with no sacrifice in quality of image or magnification or light, with great advantages ergonomically to my body and my staff, and tremendous teaching and staff development advantages. So I think it just came out of nowhere sort of for us, but it clearly was a paradigm shift, and it's changed the whole way that I operate and think about operating. And frankly, I think it'll add a few years to my career.